As you're aware that we did hold the hearing on House Bill 2793, and after that hearing, I got to hearing a few different little things about individuals that could actually provide consent against a parent's wishes, and then some of the things that I heard during the committee. And so I thought, well, let's bring the experts to the table and let's have a discussion so that we can learn what is actually happening out there and what might be fiction for us. So that's why I've convened this here today. And we could go through with all a bunch of introductions, but I feel like that takes some time, and I'd rather take and hear from some folks. So just make sure that when I do take and call on you, and this is just kind of raise your hand to let me know that you want to talk. This is for us to converse back and forth, so it's not like the normal conferee format whatsoever. We want to hear everything that you're willing to provide us, because we can only do good legislation if we're informed on what's actually occurring out there. And I felt like this was an important enough bill for us to be able to do that. So I think this bill came about because Representative Bryce had a constituent whose daughter was actually given, I believe it was birth control pills and the cervical cancer injection. Is that correct? Without parental consent? Representative Bryce.
Well, there are, one of them was a 14-year-old with contraceptive injections and mental health services, and then there were a couple of others that didn't want to come forward, but they had just general medical treatment.
All right, thank you. So that's how this bill came about, and so we're going to have the discussion on it today. Now, some of you I know that were involved in the hearing, so is there anyone that would like to start us off and share your opinion with us on the bill? And don't be bashful, because this is your opportunity to visit with us. Oh, so this is real easy. So we can just say none of you can have give parental consent. We'll do it without consent. So nobody wants to talk first. Okay. And you are Sarah.
I am Dr. Sarah Gilliland. I'm Director of Health Services for Olathe Public Schools and a member of the Kansas School Nurse Organization. So I'm here representing the KSNO.
And schools and nurses were brought up quite a bit during that hearing. So
yeah, we are quite concerned with the bill because it is so broad. It really doesn't address what we're allowed to do in school and really prevents us from doing anything in school. So why bother having a school nurse?
Okay, explain to us what you feel that this bill would prevent you from doing as a school nurse.
I think that the language is so broad that it really prevents us from doing anything unless a parent says we can do something. So if a student comes in with a stomach ache, are we allowed now to perform an assessment or not? It's not necessarily an emergency when a child comes in with a bellyache, but it can be. And if I can't do an assessment, then that impairs my ability to be a school nurse. If a child comes in with an earache, am I allowed to take an otoscope and look in an ear? If a kid says, I have a bug crawling out of my ear, am I allowed to take that bug out of the ear? So there's just the language is so broad, it doesn't seem to let us do anything as school nurses.
Okay, so how could we fix that? It's like, do you understand the gist of what our concern is from a legislative perspective, that things are happening treatment-wise without parental consent?
Correct, but when you send a child to school, you have implied consent that the child is going to receive some medical care at school if the child comes to the school nurse. And here we just don't know what that is now.
Well, see, I would beg to differ that because I'd send a child to school that it's implied that they're going to get medical care at school.
That's what I'm saying.
I would disagree with that.
You would disagree with that?
Yeah, then it's not implied consent because there are consent forms that are used on a regular basis for all different types of things, whether it's a
I
field
agree,
trip,
for medications, for things that are invasive like medications, yes, we need a consent. But do we need a consent for a child to come see me to tell me they have a sore throat? Well, and can I look in that throat?
And that's not what we're looking to get at. We're looking at treatments. You know, is giving a child birth control a treatment?
Sure, but is giving a child a saltwater gargle a
No,
treatment?
I just asked you a question. Is giving a child birth control pills without parental consent a treatment?
Yes.
And you think that should be allowed by schools?
No.
Okay, so that's what I'm saying. This is what we're trying to get to,
Correct.
is to address treatments that really should have parental consent.
Correct, but
So
the
that's what we're
language in
looking
the
at.
bill is so broad. It
Well-
needs to be tapered to the things that it specifically needs consent for. If you want consent, then outline what you want consent for.
And that's what we're here for today, is to get ideas on how we could provide what was talked about and the needs that were recommended and suggested. So we're looking at making changes to the bill. But the discussion I want here today is I want ideas, solutions. I want to know what you think you can do, what you can't do. Because if you're here just to say no, 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 no on the bill, that's not going to get us where we need to get. We're looking at how can we make changes to the bill. So that's what this open discussion is all about.
So my suggestion would be have a list of things that you want consent for.
Well, how broad do you think that your consent as a school nurse is?
My consent, so when a child is sent to school, I'm allowed to operate under the board policies and my license as a registered nurse.
Okay, so,
So my scope of practice is my RN license.
and under your scope of practice, are you not required to get parental consent?
No. Not for what we do at school. The board policies and what we can do at school are what we do. Can I prescribe? None of us are practicing as nurse practitioners in school, so we aren't going to be prescribing anything.
Right.
So, but my scope allows me, my scope of practice as an RN allows me to assess body parts, including anything, head to toe. My scope of practice allows me to do an assessment. My Board of Education allows me to do an assessment. My Board of Education lets me do certain things. If I'm giving a medication, I have to have parental consent. It's not written in the board policy.
Okay,
So,
all right, thank you. Somebody else over here had their hand up. Representative Bryce.
Yes, thank you, Madam Chair. I looked at this a little bit myself, asking different school boards what they did. And what they did was they provided a consent form at the beginning of the semester or the beginning of the school year. And there's apparently not a generic consent form for all school boards. That might be something the Kansas School Board Association might want to look into. But it is a consent form because that kind of gets to the heart of the reason I brought this bill is there seems, for those that don't know, I'm an emergency room physician, and I've practiced for nearly 40 years, and I don't think I've ever treated a minor without parental consent unless it's a dire emergency. And so when I heard from my constituents that were very angry about this, that it's being done without their consent, and not only that, without their knowledge, that's what generated a look into things and to see. And sure enough, I was surprised to find that as you described, these sort of things are happening. But I think the easy fix for a school or a school district is to just have a consent form at the beginning of the semester, beginning of the year. Parents either agree to consent or they decline to consent, and that's what some of the school districts are doing. Thank you, Madam Chair.
Was there someone over here that had their hand up? Representative Barth.
Yeah, thanks, Madam Chair. I have a follow-up questions for you, probably 2 or 3. So the full scope of your nursing license, you're talking about utilizing and doing an assessment for anything and everything that a kid might have a problem with at school. I just like some further definition or description from you on that assessment. So that's my first part. And then my second part is going to be underneath treatment as well, and what you consider that to be. I know you said medication has to have parental consent for that. But if you could start with those two, and then I might have a follow-up question from there. Thanks.
Okay, so first question is, what is my scope of practice as a registered nurse for assessments? So I can assess just like I would, a nurse in the hospital would go in and visit a patient, do a head-to-toe assessment, check vital signs, listen to hearts, lungs, bellies, look at skin, whether that skin be on the tip of their nose or on the tip of a penis. I can look at that skin as well.
With some of the things you're talking about, do you have to have an adult in there at some point in time when you're looking under clothes and things of that nature?
So that depends on board policy. So our board, I'm not going to speak to our board policy, but our recommendation to nurses is they have somebody within the room, but still provide privacy to the child. So the person who is in the room does not see the child, but can hear everything that's going on.
Okay, and then of this assessment, is it required for you to, is it required for you to let the parents know you did an assessment and what you did?
No. Because if that was the case, and I see 80 students a day, I would have to call 80 parents before I saw their student.
I don't think parents are aware of this, and I just had 2 kids graduate from school in the last few years. So I think this is also part of the problem is people like myself who as a parent don't even know that nurses are possibly doing this with our children, looking at body parts and things like that as well without us knowing what that assessment. And then we definitely, I don't think, knew that we're not being told that if they did. So maybe.
Well, I think most nurses, sorry to disagree, but most nurses, if they're going to so much as look as a child's body part, are going to call a parent. But is there a law that says that we have to? No. But again, if your child was in the hospital, the nurse would come and assess your child in the hospital. And if you weren't there, you would not necessarily know that the nurse had looked at your child's nose, armpits, buttocks.
And I don't
But
know
I
the
think in a
situation.
hospital setting, that's expected. And consent has been signed by the parents when that child was admitted. So that's a totally different type of an environment. So I would disagree there.
Okay.
Someone else over here have their hand? Representative Berg. Can't.
Thank you, Madam Chair.
I had to remember which Berg I was calling.
Yeah, nameplates are a little switched. Representative Barth kind of asked my question about parental notification, so
Okay.
that's what I was going to ask. Thank you.
Okay. Anyone else want to comment? You know, one of the things that we heard about, well, first of all, I just want everyone to understand, if you don't speak up here and then you come in and complain later, there's not a whole lot we can do about it. This is about us changing a bill today, so you can either be a part of the solution or not be a part of the solution. You can't be bashful on this. Some of you have attended these types of roundtables before. One of the things that we heard about is that we have some healthcare providers that actually have the ability to declare a 14-year-old mature enough to consent. Can anyone help me with that? Rochelle.
Hello, I'm Rochelle Colombo, Executive Director of the Kansas Medical Society. And if I promise to answer your question, Chairman, may I begin with a statement about our position on the bill?
That's fine.
Okay. So I think of the roundtable, I'm probably the only proponent that was here on that day and that is here at the roundtable. And so I wanted to begin with a statement about our position, which is that, and I'm not going to speak for others, but I think there are 2 different issues before us. One is the intent of the bill, and the other is the way that it plays out. And so the Kansas Medical Society spent some time talking with Representative Bryce, and we do agree with the intent of the bill, which, as we understand it, is to ensure that the person providing the services cannot provide the informed consent for those services, except with a limited number of exceptions. And there are many things that we are talking about here today, or that were talked about in the hearing, that may or may not be included. And so even as a proponent, I would like to offer some suggestions for clarity. And one would be that the exceptions that are listed in the bill that are referenced only by statute, that those statutes then be repeated in the bill so that it's very clear. And when you read the bill, that when it refers to, you know, whichever statute that you have an understanding that this doesn't apply to an emergency situation, for instance. Because it was our belief and understanding that the bill was not intending to restrict what is current law today, in certain exceptions where it's important that minors are able to be taken care of without immediate parental consent, or but instead that and this is the answer to your question, Madam Chair, that instead it did provide codification for something that the law is silent on right now, which is the mature minor doctrine. And the mature minor doctrine, as I understand it, is something that's been established by judiciary ruling and an attorney general's opinion, and is referenced several times in instances where a question comes up, and because the statute is silent, there are times when they rely on this mature minor doctrine. And that is the answer to your question, is that there are times when a 14-year-old has received care without the knowledge or consent of their parent, and it has been allowed under the mature minor doctrine because the law is silent on certain situations. And it was the position of the medical society that it would be appropriate to clarify when that is appropriate and when it is not, with the understanding that the things that are already listed in law as exceptions for minors should be repeated in the bill. So I should clarify that there are at least 2 exceptions that were not repeated in the bill as I understand them. And one is for minors that are receiving care for a venereal disease. And the statute number, give me just a second, is 65-2892, and the other allows a provider to treat a minor patient for substance abuse, and that's 65-2892A. Now,
What was the last 4 numbers?
2892 and 2892A.
Okay.
So the final thing I'll say about that is, if it is the will of this body, that's a policy question for the legislature. You know, that's really what I think we're here to talk about today, is when is it appropriate for a minor to be treated without the consent of their parent? Our position stemmed from the belief that the law was silent for a number of exceptions under the age of 16, and that by establishing this law, it would be clearer that minors should not be receiving care that their parents are not informed about, and that would be consistent and would not establish or restrict, it wouldn't restrict any rights, it would just clarify and codify what is appropriate. So it would be our position that if it's a policy decision for the legislature if they're looking to change something from current law as it relates to consent. But my understanding was that the emphasis of the bill was really to codify around mature minor doctrine. And so I'd be happy to answer any questions on that front.
Thank you. Representative Vaughn?
Thank you, Madam Chair. Thank you, Ms. Colombo. I was just wondering if you could speak more about the mature minor doctrine. Do you know where that came from? And kind of in regards to your comments, are you suggesting that, so to codify current law, that would mean removing the 2 exceptions that are currently listed in the bill and just having it as is to say this is current practice? We're clearing up any gray area? I just want to make sure I understand.
No, I'm glad you asked that question. So let me try to say it more clearly. The law has been silent. There is nothing, the Kansas statute doesn't establish the mature minor doctrine. So Kansas statute doesn't say, for instance, that a social worker or an APRN or a physician can provide informed consent in the absence of a guardian or a parent for a child under the age of 16, carte blanche. But an attorney general's opinion does. And so it was my understanding that the bill was introduced to eliminate that gray area, and that it wouldn't provide inconsistencies with what is already established. And so no, I was saying that in order for it to be consistent, those 2 areas would need to be addressed, 65-2892 and 65-98, I already said it, 92A. And I understand there may be disagreement about that. There might be some folks that say, well, those are instances where parents should be involved. Others would say, no, they shouldn't. But current law already accepts those and says that they don't require that. And so it would be consistent to add an amendment to add those to the list of exceptions. Is that clearer? Thank you.
It is. Thank you. Thanks, Madam Chair.
Representative Clifford.
Yes, Madam Chair, I might defer to the reviser, but the bill contemplates repealing 65-92A, right? So that's on the table for discussion of whether the bill's going to repeal that or not.
Both 2892 and 92A?
Madam Chair, it just says 92A, I think, Section 2. What line is that? Anyone have the bill out?
Madam Chair, I have a question. I know that Revisor Moyer's not here today. I was trying to remember if when the bill was heard, she mentioned that there was a technical error in the bill that had to do with, I believe it was 92A. And I'm imagining that the bill sponsor could answer whether it was intended to be included or not.
Well, and if, as we look at the bill, I have a note that shows there was an error on the repeal up there because it was KSA, it says KSA 38-123, but it's actually KSA 38-1236 is the other one being repealed, and it's silent on 2892. B? Oh, B. See, I can't even read what I've got there. So 123B instead of just 123. So that's the other statute that's being repealed.
2892 is being repealed?
B,
Line 32.
A is. Yeah, it's silent on 2892. Yeah, because it's up here in
Oh, I
the,
see.
in the top.
So, Madam Chair, if I might, to me, a very helpful beginning place, I think, for consideration of the bill, I said it now 3 times, but would be, again, if those things were clearly listed out rather than statute number, because there are many exceptions, and then there's a couple of repeals. And it's just, even for someone who's been in this environment a long time, it's tough to go back and cross-source those and know exactly what's in or out, and I just think it would be helpful for clarity.
All right. Representative Orpeza.
I had a quick question for Representative Price. When you say a 14-year-old was given contraceptive, was that at the school or where was this?
FQHC.
An FQHC? Okay, thank you.
Was the FQHC at the school?
It was renting space from a school.
So it was in the school, yes. Does that help?
Yes, that does help. And then I have another, quick question
That's
for the
fine.
reviser. Does this bill remove any school-based screenings?
I'm going to look into that and get right back to you, Representative Orpez, if that's all right.
Okay, thank you.
Thank you.
Rachel.
Thanks for holding this, Madam Chairman. I wanted to suggest that 2 of the exceptions be stated a little more broadly to ensure that no child welfare services could be interfered with by this bill. We have a specific citation of 382216 and 382217. However, when you consider that the BSRB licensed individuals are considered healthcare providers by the definition of this bill, pretty much any licensed person working in child welfare, which has traditionally to date not been defined or understood as healthcare, might be caught up in this and might wonder, how often do I need to call the parent back about another conversation I'm having with their child on my caseload, might be a concern. So I think if you just broadly would exclude Chapter 38 as standing, that it would make more sense to those of us who practice in child welfare. And I do want to echo, the reason I rung in now is because, as Rochelle mentioned, I was unable to even figure out what everything could have meant by the time the hearing came together. So I do also encourage that exceptions be made very clear, because as I am trying to do a whiteboard, I feel like my brain is on the fritz a little bit about all the different definitions of healthcare providers under different sections of our code. So that's one easy answer. I have some other areas that are less easy, but that's my first one that's more
Well,
easy.
and Rachel, we actually have in the bill itself, the provisions of this section shall not apply to, and we have KSAs 38-122, 38-123B, 38, which is kind of interesting because of that what it says on top. 38-137, 38-2216, 38-2217, 65-2891, 65-6704, and 65-6705. So I can see where that gets confusing, because unless you know those statutes, which no, I don't, I have to talk to the revisers or look it up in the book, so.
And Madam Chair, I did go back and print every single one of those, and none of them cover child welfare general practice or general case management, maybe in other areas as well. So
Okay.
I'll throw that out and then let others potentially have,
Okay,
they'll
so
cover
are
my
you
other stuff.
Are you suggesting that we need to put something in there to clarify that it doesn't?
Yeah, my suggestion would be, broadly speaking, is the child in need of care code, any services performed by a BSRB member under the child in need of care code might be a clarification that would be warranted to make sure that anything that's being done related to child abuse, particularly child sexual abuse, rapid responses for human trafficking, child physical abuse, homeless youth, street, all of those types of situations come into the child welfare practice, and we don't want to limit our services to children who are being abused and neglected.
So then we go, so you're talking about all of our sync codes and then some additional other ones?
Yes, ma'am.
Okay. If you can get that list to us, I'd appreciate that. Okay, Emily's got an answer for us on something that we've asked her to do.
For Representative Oropeza.
Okay.
Since nurse falls under the definition of healthcare provider and a screening is part of their license, there is no exception to those screenings in this bill, so it is prohibited under this bill. Without consent of a parent.
Without consent of the parent, so we would have no hearing, no vision, no checking for lice, no evaluation for sex abuse, mental issues, mental health issues, correct? Oh, dental.
If those are screenings a nurse would provide, then yes. They would be prohibited under this
That
bill.
would be prohibited under this bill
Without parental consent.
without parental consent. Okay.
So we could do some clarification on it.
I would ask for that, please.
Oh, Representative Reese. I should look at my list you're providing me.
I'm trying to. I'm not a,
You're doing good.
my writing is terrible. Thank you, Madam Chair. I need some clarification again about where the prescribing of the contraception happened. So my understanding now is that it was not done in the school, done in school building, but it was an FQ practitioner that prescribed the birth control.
Because they have a facility in the school.
Right, but it's
So
really
that's
the
probably in place of their
FQ.
nurse. It's probably in place of their nurse. Because they've hired them to be in the school rather than having a nurse on site.
Okay. And I had another question. Oh, can I ask a question of a person who is here?
Yeah.
Yeah. Randy, Director of Wyandotte Center, Randy Kallstrom. Randy, can you speak to the exemptions that are in the bill, but now we see that one of them might be taken out, has to do with the substance abuse, and the other one was for venereal disease. I thought a 14-year-old could consent to an assessment for crisis mental health services or maybe even an admission to a hospital?
No, you got to push the button there. And then pull it to you. You almost have to eat it. If it'll, as far as it'll go? Okay, all right.
There we go. So, thank you. And again, I'm Randy Kallstrom. I'm the CEO for Wyandotte Behavioral Health Network in Kansas City, Kansas. And the statute of which we comply with regarding consent for treatment is KSA 592949, which authorizes a 14-year-old to make application to a treatment facility for behavioral health, whether that's substance abuse or mental health. And we are, by this statute, allowed to do a one-time assessment, but then are compelled to inform the parent or guardian in writing and not allowed to continue to provide treatment beyond that initial assessment. But if I could elaborate, Madam Chair?
That microphone slide over there easier. Has it got a longer cord? It doesn't have a longer cord.
I'm trying to do my
You know what?
Elvis
Why don't you cozy
impersonation.
up? Just cozy up to Rochelle. Just slide your chair over there, yeah. She doesn't bite most of the time. I can't guarantee she doesn't, but there we go. That'll be better for you.
Is that better?
Yes, thank
Oh,
you.
you're welcome. Thank you. May I elaborate?
Yes.
And the reason why this is important to this conversation is a 14-year-old, 15-year-old, 16-year-old may come to a mental health center seeking help. They may or may not be in crisis, but until we do that assessment, we don't know. So they could be at imminent risk to harm themselves, suicidal ideation, or they could be a risk to someone else in having thoughts of harming others, perhaps, not to be dramatic, but perhaps contemplating a mass murder of some sort. But until we do that assessment, we would not know. Likewise, we do mobile crisis response. In fact, we do mobile crisis response to schools in Wyandotte County. Sometimes parents are able to be reached by the school, sometimes they're not. But again, in the same situation, we have to, it's important, I should say, to be able to assess the student or the child to determine, are they at risk of harming themselves? Are they at risk of harming others? So that we can get them into the right services. Again, our responsibility at that point would be to locate the parent or guardian in order to seek hospitalization if that's what was determined was necessary. And as I already provided information, we would notify the parent of the results of that assessment anyway. But there are also unaccompanied minors in the community, which we can have a conversation of why that happens or shouldn't happen, but the fact is it does. And it's important that unaccompanied minors are able to get emergency psychiatric help as well. There is a provision in the bill about emergency medical care, but again, it's not really readily known. Is this a crisis or an emergency for mental health until we do that initial assessment?
So when you talk about assessment then, Randy, do you have the ability to treat before you can get hold of the parents, or how does that work?
We would do a crisis intervention. So if someone was reporting suicidal thoughts and ideation, we would go through crisis planning with them. Again, we would also then inform the parent or the guardian of both the assessment results and of the crisis plan that was developed with that child.
Okay, and then when you talk about a crisis plan, would that involve any medications, or is that just trying to verbally communicate, verbally calm, et cetera, with the child?
Yeah, no, it would not be prescribing medication. It would be coming up with, when you have these thoughts of suicide, what can you do instead? Who is a safe person in your life that you can confide in and talk to, those types of things.
All right. Thank you. So then, do you guys have then a suggestion that you would like to see added to the bill to allow you to do it? Because I know I've had some conversations with some of your folks in this industry, is that you were worried about how to handle the crisis. So I'm wondering if it doesn't have to do with addressing what you operate under on the one-time assessment maybe, and clarify that language a little bit?
That would be my recommendation, if I could, to make it more explicit, because people will interpret things, and I would worry about my own staff who would have knowledge of the bill passing as it is written today, and then my own staff going, I'm not doing anything, I'm not touching this child,
Right.
and then we all have a problem.
Right.
So, and I would recommend or suggest, if I could, that the language be consistent with the statute that I cited earlier.
Well, let me ask you, Randy, this kind of brings up, because you're involved with the MHIT program that
Correct.
we have in some of the school buildings across the state.
Correct.
So are they underneath all of that, because the parents have consented, if medication was determined, then you would be able to administer? It's probably rare.
It is Wyandottes policy. We're not going to prescribe medicine to a child without the guardian or parental consent. Our biggest issue is when we have split parents and one parent says yes, one parent says no, how to manage that. But that's probably a whole different hearing.
Okay. Yeah, we're not going to go that far into that. For good reason. Let's see, ks.gov.
Thank you, Madam Chair. Casey Dahlke, Executive Director for CACs of Kansas. We're the state chapter organization that provides support to all of our 17 child advocacy centers across the state. And so we get to work with the child abuse cases, more frequently child sexual abuse. And when our members, so all of our centers, take a look at this bill, and I understand that the exception of 38-2217 talks about an exclusion for when abuse is alleged, that we don't need parental consent for that. And what I'd like to do is inform this committee of a different perspective of what we more typically see at our child advocacy centers when kids get referred to us. Children get referred to us through all different avenues, and it's not always, in fact, less frequently is it that there's an outcry of abuse disclosure first. Typically, what we see is a child gets an assessment either at school or goes in for a primary care checkup or needs to seek mental health services, and for some of these other presenting issues like UTI or a rash or infection, bladder or bowel incontinence or dysfunction, obviously the STI treatment, which we've already addressed, but then presenting for just a general health exam or suicidal ideation or threat of harm. For potentially there's a reason of that with the abuse in the background, but we're not going to know that up front without that assessment occurring. And unfortunately, I know this is going to be hard for some of us here to wrap our heads around. When we're talking about child sexual abuse, 88% of the kids that we served last year, 4,400 children, 88% of those children knew their offender or were related to their offender in some way, shape, or form. And what we see at our centers, unfortunately, is the parent caregivers will oftentimes, most cases, defend the offender over their child. So what we are seeing is, and what we see as a concern here is, at what point could the parent be in an exam or in a treatment of some sort with their child, not knowing that there's a concern of abuse there, but if the child makes a disclosure or if the exam takes a turn and the parent gets concerned, could they pull consent and then leave with the child? And at that point, we're talking about interference with investigation. If we're getting to a place where there could be alleged abuse taking place, if the parent pulls consent, takes the child home, and begins coaching, as we know happens, by the time a report's made and investigators have an opportunity to speak with that child, they've been coached in some manner to where they wouldn't be able to come forth with that information as they would have potentially in a generalized assessment. Many of our kids don't know that the abuse is wrong either. And so, allowing the space for our healthcare providers to provide those initial assessments, we as CACs feel is crucial to ensure safety of all children and make sure that needs are being met effectively.
Well, let me ask you, Casey. I was kind of under the impression with child advocacy centers that a lot of the cases that you dealt with probably came in via law enforcement, but you're saying that that parents are coming in voluntarily?
Yeah, that's not correct. I'll clarify for you, Madam Chair. Thank you for that question. We do get our referrals from law enforcement and or DCF at this time. That's how they get referred. And what I'm referencing is the initial outcry or the initial discovery of the alleged abuse that causes whomever that person is, healthcare provider, school nurse, whomever, to make that report to law enforcement or DCF is what I'm referencing, that initial outcry.
That assessment?
Yes, madam.
Okay, all right, so it's not necessarily your assessment, it's the individual that's going to refer to you. And I'm a big fan of ACACs. I was actually involved in the original legislation, so
Thank you, Madam Chair.
Without the forensics that you guys do, we wouldn't have some of the convictions that we get.
Yes, thank you.
Representative Warpeza.
My question is I don't know if anybody here has this information, but how many reports are made to DCF in the state of Kansas from a school nurse? outcries, sexual abuse, abuse in general?
Is that something that Sarah or KSB can answer for us?
Sorry, I don't know those numbers, Madam Chairperson, but I do know that as a nurse, I made more reports to DCF than I ever did as a nurse in a hospital.
Right.
Because we see the children every day.
Madam Chairman, I hate to say this if I'm not accurate or my memory is not serving me, but I hate to not say it to the extent that I believe this is true or was recently true. DCF may see up to 80,000 reports of abuse in a year, and the vast majority of those are from schools. So that, to the extent that that's helpful, it's many thousands.
Yeah, go ahead.
I have a follow-up question. And so what you said, Casey, is that that was purely from an assessment standpoint, that these are then gone up the chain to report it to DCF, correct?
That's correct. A medical assessment from a
Yes,
healthcare
a
provider,
healthcare
whether that's
provider,
at a
yes.
hospital, at a mental health clinic. Yes.
Okay. And 80,000 about, potentially?
It was a blow your mind kind of figure, and 80,000 is what is in my mind when I heard
Okay.
it.
And, okay, thank you.
She's been around the block a time or two, I think, on this. So let me ask you, is it still, because I haven't done a lot in the area of foster care for quite a few years, is it still the case that DCF could get that call, but that child's not going to show up at a child advocacy center without law enforcement involved? Would that be correct? Because law enforcement can remove a child, but I don't believe that DCF can remove a child.
Law enforcement does not have to be present. DCF can refer, and in those situations where DCF would refer a child to a child advocacy center, that's where you're going to see frequently that parents will attend with the child.
Okay, when you say referred, does that mean that DCF brought the child to you or the parent brought the child to you?
Unless they're in, well, even if they're in state's custody, DCF won't transport. DCF does not physically bring children to our office necessarily. They'll refer. So parents would bring, or the foster care agency, that if the child's in foster care, then the foster parent would bring them.
Or law enforcement?
Or law enforcement,
Right.
yes, ma'am.
Okay. Monica?
Thank you, Madam Chair. I appreciate the seriousness of the topics that we've considered so far. I'm Monica Kurz. I'm with Headquarters Kansas. We're a 988 suicide and crisis lifeline provider here in Kansas. We provide our services primarily over the phone and also online text and chat services. So one of the things I'd like to bring to the committee's attention is the difficulty that will come in for 988 services in providing those crisis assessments and also safety plan suicide interventions over the phone or over text and chat. So we know that nationally, I was just looking at the number, over 40% of our text chat numbers to 988 are coming from individuals under the age of 20 years old. I'm sure the committee can appreciate that when you're speaking on the phone or you're texting or instant messaging with someone, that verification of age and also verification of parental consent is something that is pretty difficult and also may not be a timely consideration. So I would bring to the committee's attention the need for addressing that particular eventuality, especially given the rise in suicide that we're seeing and also the utilization of that service.
So Monica, with the 988, because there's follow-up required.
Yes.
Of anyone that contacts 988. So if you get a call in then from a minor, is there efforts to make contact with the parents?
If that follow-up is going to be happening in person through, say, a CMHC or a CCBHC, it is far easier for them to get consent for a minor. We're not necessarily going to seek parental consent when we're providing those via phone and text chat,
Right.
simply because we can't verify the identity of an adult who is talking with us. I have no idea if someone who is saying that they are a caller's mother or father is in fact that caller's mother or father. So when we have individuals who are licensed by the BSRB, and I think we all want folks with that level of licensure being able to provide 988 services, that parental consent is difficult. I think we've been operating kind of based on statutes as they're written and being able to provide those services. So I have some real concerns.
So when the follow-up has to take place after a 988 contact, which means a call into 988, is that done then by the CMHC or the CCBHC?
It's dependent on the contact. So we do have individuals who we're referring out to mobile crisis or who are already service connected with their CCBHCs. But if they're not service connected, if they're new, then likely we're doing that follow-up via phone or email because there's not necessarily in this field person to do that in-person follow-up. And so we're wanting to make sure that any safety plans that we've created are being followed. If we've helped them or encouraged them to make an appointment with a CCBHC, we feel it's our duty to do that follow-up to make sure that we're talking with them about whether or not that service was something they took advantage of. So it's just not always possible within those first few contacts to make in-person contact. We'll certainly refer with parental consent. Although I will bring up, Randy, that when we're doing and referring for mobile crisis, that's not something that we're going to seek consent on the phone for. We're going to go ahead and send that person and then let them sort out the consent when they get there.
So this is a little bit off track, so it might be something from a 988 perspective that we need to track is how many that we're able to follow up with and how many we're not able to follow up with.
Yeah, and I think one of the things that I would add to that is how many of our contacts are anonymous versus non-anonymous. And so sometimes that kind of in-person follow-up is really going to be dependent on the person's comfort. I'll echo what some of my colleagues in the child welfare and child sexual assault spaces are saying. We're very often a safe space for folks where we're going to hear about things for the first time. We try to be pretty careful about the messages that we're putting out there because we certainly don't want to limit the access that a child has to a safe adult. And we know that that text message is very often the thing that is going to be what the child has access to that perhaps their abuser does not have access to.
All right, thank you. Representative Bueller. No? Oh, Representative Bryce.
Thank you, Madam Chair. That was a compliment for me. One thing, thank you, Monica. One thing when we pondered with this bill, and one thing that I had in mind also was what you're bringing up. And one of the exceptions in the bill, and I don't know the statute number, but one of the exceptions is if there's a threat to the life or the well-being of the child, you go ahead and treat them or evaluate them prior to parental consent. So my intent, and the revisor can correct me if this is not exactly right, but the intent of the bill is that if there is a suicide hotline, I think by definition that's a threat to the life or well-being of a child. And so there would be no hindrance from going ahead and providing care. And also, to some degree, I think that applies to some of the mental health services Randy brought up, which would be if you talk with a kid and there's a threat like going to do a mass shooting or whatever, there's no consent barrier for doing the appropriate thing for these things. So I just wanted to bring that up. That's the intent of the bill, and the revisor can correct me if I'm wrong, but it refers to one of the statute that says, I believe it's life or well-being, you don't require consent ahead of time. Thank you.
Representative Warpeza.
And my concern when looking at this bill, and I do understand everybody's position here, is that we're not even able to get to that point because we can't assess. It really just cuts us off at the knees because we can't even evaluate the situation to see if there's truly an emergency there or if there's something else potentially going on with the child. We just can't even do the assessment because that's a healthcare service.
Well, and that's why we're here today, is to figure out what is missing in here that we need to have in here. And I think that we can definitely have that discussion. Representative McDonald. And then I've got Amy and Connor. And Andy. All right.
Thank you, Madam Chair. I want to echo Representative Orpeza's comments. I feel like we can't even allow triage in so many areas that this broad is kind of like we're just trying to put lipstick on a pig. There's not a way for us to make this to make our medical providers in the state of Kansas feel safe. And medical providers include anything from dentists to hygienists to physical therapists to school nurses. So I think it's probably an overcorrection. I understand we are worried about children and their safety, but also we live in a place, we're fortunate enough to have so many caring people in our communities to take care of our kids. And I guess the biggest problem I have with this bill is the fact that we're assuming ill intent. We're always looking for everybody to be a predator or everybody's, got bad intentions with our children. And I just want to go back to what I said the other day. Like, we need to teach our kids to look to the helpers when they need help. And these are the people who are the helpers. Who are we as legislators to step in and tell them how to do their jobs within their scope of practice? I just think it's a huge overstep. And so I don't want us to overcorrect. And I feel like that's what this bill is. Thank you.
Amy, you're up next.
Thank you. Amy Campbell, Kansas Mental Health Coalition. When we presented testimony, that was one of the aspects of concern that I had, was about this emergency statute that we are hoping to protect providers. If you read it on its face, it doesn't really speak to behavioral health. And I think it's a little bit of a stretch to assume that all of these crisis situations will come under that statute. I also want to remind the group that we don't refer to the Care and Treatment Act for mental health in this bill at all. So that probably needs to be there. And then in my research, I was contacted by several social workers who talked about federal requirements for teenagers and substance use treatment that this bill seems to directly conflict. And I would recommend that somebody with a better legal degree than what I have, which is not one, look into that, because we don't want to do something that is directly conflicting when you have professionals that are having to comply with both and putting them in an area of jeopardy. And then, so when we talk about constructive areas, I think reaching into Kansas statutes and pulling all of them in is an excellent suggestion. It just gets very, very broad. And I'm wondering if it isn't better to go back and look at your definition of treatment and be more narrow and specific about what you're trying to target in this situation. We do not want to discourage clinical folks from volunteering for working on the 988 crisis line. We don't want to have we don't want to have non-clinical folks providing a lot of this initial screening and assessment when we could have clinical folks. And I think that that's kind of where we are. Thank you, Madam Chair.
Andy?
Andy Brown with ks. And I think, one of our primary concerns is what Monica was speaking to, which is what happens when there's a behavioral health crisis of some kind. We don't want to put licensed practitioners in a position where they're having to make a choice between protecting their license and protecting a life. I also feel like this applies to a lot of other situations besides just the 988 crisis line. We have substance use and treatment referral lines. We have independent crisis lines at 26 of our CMHCs across the state. There are support lines and warm lines and sexual assault report lines. There's tons of hotlines across the state that were operated, and oftentimes staffed by people that are licensed and have licenses to protect. And I think there's concern that this could have a negative impact on the provision of those services across the state, and also in the follow-up care that individuals that call the lines receive. And I'm not an expert on what happens after phone calls. I'm not going to stand here and pretend that I've got a legal degree either. But I do just sense that there's going to be a lot of confusion and a lot of wariness on the part of licensed practitioners about how to engage with anybody who appears to be, below the age of 18. And it's going to be very hard to make that determination over a phone line And it's concerning. And then I think also, you know, when we show up as a crisis response unit to a house or to a school or to a neighborhood, if that parent isn't there and able to provide consent to treat at that point in time, we're creating a barrier at a very critical juncture. So those are the concerns that I think as an agency, KDADS has around crisis provision and the language in the bill.
Thank you. Next, I have Tara and then Connor.
Thank you, Madam Chair. Tara Remington Brown with the Kansas Academy of Family Physicians. The one thing I want to state is I think the intent of this bill is what we can all agree on, which is protecting our children. We were opponents of the bill as it was written, but I think that KMS offers a good solution, which I think would align or answer a lot of questions that folks have, which is that if we look to legal statute that defines a minor, we can answer this question very quickly. I did have a clarifying question, if I may, Madam Chair. In the fiscal note, it mentions that this is relational to the Board of Nursing, as well as Behavioral Sciences Regulatory Board, but it doesn't address the Board of Healing Arts. However, the language in the bill states healthcare providers. So I'm just curious what the intention, who we're trying to address this with. So. The fiscal note that I'm referring to is dated February 14th from the, oh, okay.
I think it could very well be Board of Healing Arts as well. It may just be an oversight, but I'd have to go back through the bill and define that, but good catch.
Thank you.
Thank you. I can't always write and talk at the same time. So, Connor?
Thank you, Madam Chair. Thank you for hosting this. And I apologize for not showing up to the original hearing on the bill, but I just wanted to make a brief comment.
I think you were busy.
It's a little busy, but I did want to say thank you to Representative Bryce for chatting with me about this bill and our concerns. I did want to say, I think, back to your original comment about the ED and providing care in emergencies, totally agree. Our ER physicians would say that, yes, there's a lot of care that's provided in an emergency that's pretty clearly falls under that statute in the emergency care. I would make the slight addendum that there is life-saving care that may not be within that emergency statute. And that takes me to Ms. Colombo's comment about 2892 and 2892A. I think it would help to clarify further what are the exceptions in the bill rather than just listing the statutes, first of all. Second of all, 2892, I think being included in that list of exceptions, and then with the slight amendment that 2892A, which is the drug addiction statute, would be repealed in this bill. And I think back to Ms. Colombo's point, we would like to see that added to the list of exceptions rather than repealed by the bill. But I did want to say thank you again for holding this conversation.
Representative Haswood.
Thank you, Madam Chair. And I think this goes to Casey on the side of the table. You mentioned previously, I think one of my big red flags right now is, are we unintentionally giving more power to a potential abuser? You know, sometimes I believe in childcare maybe they're in for a headache, or sometimes they haven't had those candid conversations with their parent about which is a private space on my body, which isn't, and those conversations just come up between maybe someone being in a nurse's office and having a headache. Under this bill currently, I'm trying to understand, so if this were to pass, at what point could a healthcare provider intersect without having parental consent? Would that be if law enforcement is involved? I mean, even if it's not, if it's a miscommunication or the child doesn't know how to express what they're feeling in words. So we would have like police, DC, agents, child protective service agents, and then that would give the okay to give that care. Am I understanding that correctly?
Thank you for that question. And I mean, that is our primary concern here as well. And how can we potentially mitigate that and protect kids that are coming in for a seemingly uneventful reason, but then it turns into a disclosure of abuse of some sort or a concern to where a report maybe needs to be made. And so, I mean, I think that clarification around what the definition of concern is, again, is going to be hard in those initial assessment phases, because if, I think it's just situational. And then to say, oh, wait, parent, hold on, I need to go call law enforcement or DCF really quick and hope that they can get here in time to start an investigation is quite unreasonable. And by that time, the parent is going to either have left or reverse their consent. So I don't know that it's going to be, I guess, are you asking at what point in an evaluation should it stop and a report be made? And then my question is, how long do we wait? We have the kid and parent wait there until an investigator shows up? I just think that it's unreasonable.
That's kind of where my question was, is that if, you know, a school nurse or a healthcare professional had, you know, a gut instinct, I need to check this kid, but they don't have a parental consent on file, what would be that route? What would that look like? Would that be law enforcement's in here, now the child's in, you know, a different custody of some sort that's out of the parents, and kind of what would that avenue look like? I'm thinking of like when I was in school, my dad would work like third shift, second shift. It differed between the week, and my mom was, you know, had me and my younger brother. So maybe my parents weren't readily available at a typical 9-to-5 job to come in and get off work and all that.
Mm-hmm. And so then if the nurse made a report and then you're potentially put into DCF or put into custody or police protective custody at that time because the nurse can't get a hold of your parent to get consent.
Yeah, just to, I guess, do that further evaluation or that assessment that was brought up earlier. And maybe it's not, you know, what we thought it was.
Mm-hmm.
And maybe they just fell on the playground or something.
Right. And that's where the confusion lies, is you really can't define. It's hard to put into a box child abuse, specifically child sexual abuse, because as I said earlier, more often than not, they're not leading with that. Kids are not leading with, I was sexually abused last night, and so that's why my throat hurts today because I have an STI in the back of my throat. They don't know to say that. And so if we're cutting them off before we can even get to the assessment piece, or as I said before, maybe mom suspects that there's something going on with dad or boyfriend or whomever, and if there's any inkling that abuse disclosure could come out, it could be that mom doesn't allow consent or doesn't allow the procedure to take place or the assessment to occur because they're worried about what the child might say and then what that might do to their living status, their financial status, might tear the family up, the kids might go into state's custody. So there's just a lot of barriers.
Okay, thank you.
Representative Blacks.
Thank you, Madam Chair, and appreciate the discussion. It's been kind of eye-opening in some ways, and certainly I think we all want to protect the minors, and that's basically what we're trying to do here and trying to get to a good path down that road. I think as a parent, as legislators, we get quite a bit of comments from our constituents of potential overreach and by whatever, schools, you name it. And certainly I think we need to protect that group and have some informed consent. But I certainly support exceptions, emergency issues, abusers. There's another path there that we can go through. We can certainly, I guess we have to identify that in the bill. That might be fine, would be okay with me, because they're already violating some law anyhow. It's just a matter of getting that. And I don't see having to have parental consent to necessarily when those things do. However, when the comment comes in that when I drop my kid off to school, well, be a great grandkid now. I don't believe that's implied consent that gives them carte blanche to do anything. I think they need parental, at least some document signed at the beginning of the school that, hey, you've got the right to look at my kid's ear, or to prescribe or to give an aspirin, or whatever, maybe not even prescriptions. But we're seeing, as things are advancing, advanced nurse practitioners are coming into school that do have the ability to prescribe, so we need to kind of be prepared for that. And I don't think parents want to have their kids prescribed medication without their consent. So I thank you for the discussion. I know it's a tough call, but I do believe we need to protect our kids. Thank you.
Sarah, that brings up a discussion that we had. So are school nurses able to give over-the-counter meds?
If we have parental permission in our district, we can give over-the-counter medications.
With parental consent?
With parental consent.
Okay.
Yes.
Always worry about that because we never know what kids are allergic to or
Exactly.
can or cannot have.
Exactly. Right. But I'd like to make a comment, and I know this might be a little incendiary, so I apologize ahead of time, but there is an assumption that when you drop your kid off at school that your kid will be taken care of. And if your kid is not feeling well, they're going to be sent to the school nurse. So, or if your child poops their pants, there's an assumption that somebody's going to clean that child up. In the process of cleaning that child up, I am going to see body parts that are private. So with the language of the bill as broad as it is, it's going to be really hard for me to convince my nurses that it's okay for them to see body parts that are private.
We're here to fix this bill today.
Right.
And address the concerns. So
Right.
that's why we're asking.
And I appreciate that so much.
Yeah.
Yeah.
Yeah. So we're not married to the bill right now. That's what I'm
Gotcha.
telling you. All right.
And thank you for my ignorance because this is my first time.
No, we all have to learn. And I make mistakes in here every day, trust me. Eileen, you had a comment?
Thank you, Madam Chair. I just wanted to clarify the question relating to Board of Healthcare, or Board of Healing Arts, the definition of healthcare provider. And they are actually covered. If you look at the definition in the bill, the healthcare provider means a person or entity defined as a healthcare provider under KSA 654921. So if you go back to KSA 654921 and look under healthcare provider there, healthcare provider means those persons and entities defined as a healthcare provider under KSA 403401, and a dentist licensed by the dental board, a professional nurse licensed by the Board of Nursing, a practical nurse, a mental health technician. So you can see why that statute got wrapped up into the definition. But if you go to the definition of definition in KSA 403401, that's the definition of healthcare provider that's used by the Healthcare Stabilization Fund. And that is the one that encompasses just about anybody and anything who's required to purchase supplemental liability insurance who's in healthcare. And the first line of that definition says healthcare provider means a person licensed to practice any branch of the healing arts. I realize that it seems kind of like you're falling down a crazy rabbit hole when we put together all those definitions, but genuinely the definition for healthcare provider in the Healthcare Provider Insurance Availability Act is this long. And to put that into statute in addition with the other terms that would fold into the bill as necessary, the definition would just be unwieldy, and that's why we do that as revisers.
Okay, you had mentioned 654921 as the definition of healthcare provider, is that correct?
That's correct, Madam Chair.
And then you mentioned another one.
Well, 654921 refers to 403401. And that's the one that hopefully will benefit from some cleanup during this legislative session.
All right, thank you. Representative McDonald.
I just want to point out, not every school district can afford, like Olathe does, to hire RNs. We have made a local decision to invest in that. So with that, I think as the parent of 2 Olathe children, I have always, like you said, assumed when my kids come to school, an RN will take care of them, and if it rises to the level that I need a call, they'll call me. But if they can't get me, I certainly do expect them to work within their scope of practice, which they're licensed to do in the state of Kansas. I just feel like we're making a big thing when there's not really reason. I don't understand the impetus for this bill at all. And my colleagues across the aisle, you know, I always hear Republicans talk about local control until they don't. So I think this is just another instance where we need to talk to our boards. We need to make policy that reflects the community. And I think for our community, we've done that in Olathe, and I'd like for everyone else to respect that process.
Well, and I think, Representative, what we're dealing here is that not every parent expects to drop their child off and have health care taken care of at the school. That's not necessarily an expectation of those parents.
That's not necessarily what I said. But I think that basic needs that arise during the school day, I'd prefer my kid to stay in school if possible. And that's part of the reason we've invested in registered nurses, to be able to provide that level of help. And of course, she would make a phone call to me if she needed to. But I don't necessarily need to know every time. If my kid complains of stomach aches all the time and he goes and he has another stomach ache, that wouldn't be an immediate phone call necessarily.
And again, Representative McDonald, that's what we're trying to address here today, which would be an assessment. And that's a big difference.
I just don't see that we can triage people under the way this is written in any form. So I don't know how you fix that from a mental health perspective or a school nurse perspective.
I think we can come up with a definition on crisis and assessment. That's what I believe. And that's what I think we're here trying to do today.
I apologize for interrupting. Not everything is a crisis, though. So
no, and assessment. And I think assessment, it appears to me we've got some clarification on this, but that's the discussion we'll have after we have this meeting here today.
Thank you.
Let's see, Representative Orpeza? Oh. Okay. You're done? Rochelle.
Yes, Madam Chair. Rochelle Colombo, Executive Director, Kansas Medical Society. I had a question, and it doesn't have to be immediate, but for the revisor, I appreciated the clarification, and there are several definitions in statute of a healthcare provider, and they're parsed out differently depending on which area of the law that they deal with. And so I want to make sure that I understand it, and that maybe for the committee, even if it was just in the explainer, if not in the bill. So the definition of healthcare provider in this bill includes both the definition of a defined healthcare provider, which are those that are licensed under the Board of Healing Arts, which participate in the Healthcare Stabilization Fund, which is about 13 different provider types, but also includes dentists. So this would be in addition to a defined healthcare provider, also includes dentists, APRNs, and what was the other? Or were there more?
Thank you, Madam Chair. Ms. Colombo, I would point you to KSA 654921, which actually gives you the key to the whole mess. 654921 is encompassed there because it brings in KSA 403401, which is the healthcare provider definition from the statute for the healthcare Provider Insurance Availability Act. And then 654921 adds additional terms, and I think that was added there. It's from the risk management chapter of, article of chapter 65, the public health chapter, and picks up that I'm not sure the dental person is going to have a lot to do with this bill, but it also picks up the mental health providers because BSRB is not licensed those providers are not licensed by the Board of Healing Arts or any other board other than the BSRB. That's why that's added in separately.
So thank you very much. That was exactly my question, because it is different under the Board of Healing Arts, and understand the concerns under mental health, and that there are other folks that have been referenced extensively, the APRNs and the nurses that aren't under the Board of Healing Arts, but making sure that for most of everyone who isn't familiar with those varying definitions, like you said, that probably just a list of all the included providers. Like I said, just for even the bill explainer, I think would be really helpful. But I appreciated that explanation. Thank you.
All right, Rochelle, and then Representative Vaughn.
Thank you. Rachel Marsh with the Children's Alliance of Kansas. Since you have the revisor talking through the language of the bill, I just wanted to point out, when people were discussing the emergency provision in 65-2891, that provider, a healthcare provider definition is a third definition beyond this bill and beyond the two referenced by the revisor, and does not encompass BSRB licensed staff in being able to provide emergency or crisis care. So if we were to try to fix this bill by just looking at that emergency exception, we would either need to broaden a definition or narrow a different definition. And I know I would get into a big ball of wax if I tried to talk whether, if we make one broad healthcare provider definition encompass everybody in the BSRB, I don't know what that would impact, and I think it probably would be slightly terrifying. So I just wanted to point that out, that there's no emergency exception for BSRB licensed individuals under the current definition in this act.
Right. Eileen, you had a comment?
Thank you, Madam Chair. With regard to this bill specifically, the BSRB is already looped into the definition of healthcare provider that's in the bill. So they're in there. With regard to 65.
Eileen, how are they in there? Can you point that out to me in the bill?
Because I have 17 different tabs open right now. Let me find the right one. In the bill itself, it says a healthcare provider means a person or entity defined as a healthcare provider under KSA 654921, a person licensed by the Board of Nursing or a person licensed by the Behavioral Science Regulatory Board. And then if you go to 654921, that's where I said healthcare provider means those persons or entities defined as a healthcare provider under KSA 403401, and a dentist and a professional nurse and a practical nurse and a mental health technician and physical therapist assistant, occupational therapy assistant, and respiratory therapist, in addition to those entities that are under 403401. And under 403401, you've got all the licensees under the State Board of Healing Arts. You've got individuals who hold temporary permits to practice under the State Board of Healing Arts. You've got people engaged in a post-grad training program approved by the State Board of Healing Arts. You've got a medical care facility licensed by the state of Kansas. You've got podiatrists. You've got pharmacists. You've got LPNs. You've got nurse anesthesiologists. You've got I lost my train of thought. I lost my place, rather, reading here. You've got, I mean, there's just a huge list there.
Right. Okay. Representative Vaughn.
Thank you, Madam Chair. I was just going to point to the bill brief for this bill for the committee. It's helpful for me. It actually lists all of the healthcare providers that are included in that definition, which, as it's defined in this bill brief, does include Board of Healing Arts, BSRB, Board of Nursing, dental hygienists, pharmacists, optometrists, medical care facilities licensed by the state, mental health clinics, nursing facilities, assisted living facilities, residential healthcare facilities, health maintenance organizations, and corporations, LLCs, partnerships, and nonprofits organized to provide healthcare services.
All right, thank you, Representative. Is there any other questions, comments, ideas, recommendations? You're on a roll, Representative Orpez, so let's go.
I have one.
I haven't counted your name yet, but no, you're fine. Go ahead.
And I don't know if it's been suggested that we just get, it's been suggested that we just get consents when people walk into school. Is that something you're contemplating?
I'm not contemplating anything till I'm done today.
Oh, okay. Well,
That's why I'm here, is I'm here to
okay.
listen and then go back and formulate. That's why I'm trying to take notes and hope I can read my writing when I'm done.
So then I just have my one comment. If that is something that should be contemplated, it should be very, looked into very deeply, because when the school districts see kids, they can see 80 a day. And if we're looking for paperwork, or we're looking for consents, or we don't have consents, then we're making phone calls. And how much time are we keeping these kids out of school and not in school for potentially just a stomach ache or Band-Aid or whatever? And then do we worry about the parents who aren't giving consent? Are they hiding something? So then those are just a couple of things that have popped in my mind since it was a potential recommendation. I just worry about getting kids in and out of a school nurse's office in a timely fashion to ensure they're not missing much school.
Well, and I know sometimes, working with the MHIP program, consents are hard to get sometimes, and I understand that. Representative Haswood?
Thank you, Madam Chair. And this could be a question for you or for the maker of the bill or for proponents. Can I get another example or two of why this is needed, this piece of legislation?
I think it goes back to the experiences that Representative Bryce talked about with a couple of constituents in his area. And then we've had other legislators come forth and talk about issues that has happened in their school districts as well, where parental consent, they felt parental consent should have occurred and it did not occur.
Were those example or instances that did happen on the similar lines of prescribing birth control, or were they different type of medical situations?
Different types of situations.
Okay, thank you.
You're welcome. Representative Reese?
I'm kind of also comments about, I'm on the same line with Representative Oropesa and Representative Haswood about, the need for the bill in the first place. And I understand that consent should have been given, at least for the one example that we heard about, but I'm still very sketchy as to, it really wasn't I guess it was a school nurse, but it was through an FQHC. So it seems to me that we would hold the FQHC responsible for that, and that, there'd be not action against the FQHC, but asking them to come forward and clarify whatever their practices are, and so that we can talk with them about that versus coming up with a whole bill that is going to just blanket the entire state, and when a consent could be given, we could ask the school districts to be much, 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 much more diligent, like getting consents and having those consents be very clear so that healthcare providers can be able to do the work that they do, and not have to come and sit so that we are trying to, try to get everything in this bill so to get it as perfect as possible. I think this is a really difficult situation. I think this in my mind, this needs, we could have a task force regarding this and probably do a really good job with that versus trying to get a bill through. And so I just ask that we not follow through with this bill, and that we, and I thank you for the hearing, because this has been awesome. And
It's a roundtable, not a hearing today.
That's right. The round table, that's kind of more squared off. Square table. That's true. It's a square table. But, we've heard so many good things, and, I just get worried every time a bill that comes through that is putting restrictions on healthcare professionals, physicians, and other providers. And here's another bill we've got before us, and how are we supposed to keep our healthcare providers? How are we going to make sure that our therapists and our nurses aren't saying, I'm done. I've had it. I can't practice under, not so much the restrictions, but practicing about, wow, if I just do this, so I'm gonna lose my job, or somebody's gonna take my license, or, whatever. And it just becomes much more and more and more difficult every time. I just don't see where we need a bill for everything. And when this whole issue of consent is extremely important, and we should really have our school districts be much more diligent about trying to get these consents. And no, it's hard. But this really points to the fact that we really need consents from parents so that services can be provided for them in the school, for the tummy aches, the cuts, or, whatever, crisis services and stuff. So, I just think this is just a little overboard. Thank you. Thank you, Madam Chair.
Thank you. Are there any further comments or questions that anyone's got? Because again, like I said, we're hoping that we can come back with a draft of a bill with what we've heard here today. Representative Barth.
Thank you, Madam Chair. I just want to make a comment because I think that it's getting discounted a little bit about this actually has not only happened to Representative Bryce's constituents. I just learned of another situation where there was no consent offered to a child for receiving services. So there are parents out there who are not getting the protections they need, and unfortunately a lot of this is happening in schools.
Representative McDonald.
I just want to have a bit of a rebuttal. Not every parent is safe for their children. If I had an LGBTQ child who was in a family with religious views that did not align with that, and I were a therapist, and I'm not a therapist, but I can see why situations could be justified where you could have the triage, right? Where you could start some conversation, where you could give them tools to talk to their parents about it, because absolutely, they'd want to talk to their parents about it. That'd be ideal. But when we assume everyone's family situation looks like ours, with 2 loving parents and 2 children and a white picket fence, I think we're just fooling ourselves. So I just think this bill, I've already said it, but I don't think it can be fixed. I'm disheartened to hear that you want to still work it, but it's your committee, and I respect that. Thank you.
Well, it's not my committee, it's our committee. So that's why we come in here and have the discussions and make those decisions. And I don't think that anyone's saying that parents are perfect. If parents were all perfect and great and wonderful, we wouldn't have any need for DCF. We wouldn't need foster care. And, I know we've had discussions, you brought up the example of, a child that maybe they have transgender ideology, et cetera, that hiding it from the parents, I think, does a disservice not only to those parents, but to those children. And if those parents are going to disagree with it, guess what? That's what foster care is all about. Because a child has a right not to be abused or neglected. And we have things in place to protect those kids from that. And that child probably needs to be out of that home, if that's what's going to happen. And that's why I think the idea of not notifying a parent of what their child is going through does a disservice to that child. And we can't get them the long-term services that they need, because we can't treat it just while school is in session. Because there's evenings, there's Friday, Saturday, in-service days, holidays, and then the summer break that child's not protected. So that's why things like that, concern me, that we don't involve the parents. And if we find out that they have abused the child, and unfortunately it's no different than a no contact order. A no contact order is a piece of paper. And it's only as good as the person that it's against if they honor it. If they don't honor it, unfortunately, someone's probably going to get hurt, but then that's when law enforcement steps in, and that's when it becomes more than a piece of paper. And unfortunately, that's sad, but that's the way that the process works. It would be the same issue on a transgender child. If their parents decided to abuse them, unfortunately, that child may get hurt, but then law enforcement steps in, and then we have a process to take and protect that child and make sure that we get that child the treatment and the necessary services that they require. So it's no different than a no contact order. Unfortunately, everything we deal with is just a piece of paper until a bad thing happens. And that's how that kind of works. So All right, committee, we've gone a little bit over our time here today, but I want to thank everyone that participated with us today, because I know that you've all got busy schedules. If you have other things that you want to share with us as we're going forward with this, you have ideas that you thought of, said, oh, gee, I wish I had brought those up before I left today, make sure that you get those to us within the next day to 2 days. I don't know when we're going to work this yet. It just depends upon how much we can cultivate from what our discussions were today, but make sure that you get them to us because we asked for the experts to be in this room on both sides of the issues for a reason. So I want to thank each and every one of you for being here. Committee, we are adjourned, and unless something comes up, there is not a meeting scheduled for tomorrow. There's a possibility that we will have one tentatively because I think right now we're on the call of the chair for Wednesday. Is that correct? So we're adjourned until further notice.